There you go. Try again.
Right. Welcome to everybody participating in this virtual meeting. Can I make a start, please, by apologising for us starting slightly later than advertised. We had additional business to conduct in the private part of the board meeting that we have before this one. Acknowledging where we still are with the COVID situation, this public meeting is being held virtually and will be video recorded, and copies of that recording put on our website for members of the public to view in the event they're not able to attend today. We are observing social distancing guidance, particularly those of us who are in shared rooms, and we will keep the situation of how board meetings are conducted in 22-23 under review, but at the moment we are still of the view that they are best done virtually, but arrangements will be considered. The chat functions in Teams is disabled until public questions, so just to warn people that they will not be able to use it. And members of the public have been invited to join the meeting via Teams, and questions will be taken at the end of the public board session. Some questions may have been submitted in advance, and if that's the case, then I will ask executive colleagues to read them out for us. We will observe usual virtual meeting etiquette of board members raising hands, and we will try and ensure that the person who first puts their hand up is asked first to make their comment. And this is a very full agenda, as year-end agendas tend to be, with the number of assurance reports that we need to consider for statutory and regulatory purposes. So in the interests of not overrunning a tight agenda, may I ask colleagues to not prolong discussion and make comments and questions short and sharp, and the answers focused and pithy. Thank you very much indeed. I have apologies from Peter Goldsborough, non-executive at Imperial, and I am aware that both Nick Ross and Beverly will need to leave early in the public meeting, but it's marvellous that you can stay for some time, but please go whenever you need to. And I would at this stage love very much welcoming and introducing Matthew Swindells, who is our incoming chair in common across the 4 acute trusts in northwest London. He's here as an observer for this public board meeting, but at an appropriate point later in the agenda, I will ask him to introduce himself, but we will crack on with the main subjects of business before we do that. But welcome, Matthew, it's lovely to have you here. Declarations of interest. Are there any declarations of interest that members need to advise us of which have not previously been notified to the Secretariat governing any matter that's on this agenda? Thank you. I'll take silence as we needn't worry. So can we move to our approving the minutes of our meeting on the 19th of January? The Secretariat hasn't been informed of any corrections or comments before this meeting. May I take them as an accurate record of our discussions on the 19th? Thank you very much indeed. Again, I'll take silence. And then for noting, we have a record of items that we discussed in our Part 2 board meetings on the 19th of January and our Trust Board seminar on the 23rd of February. Note these are private discussions, but here is a suitable note of what we spoke about. And I just take that for noting. If we could move on to matters arising and the review of the action log, and could I ask Peter to take us through that, please?
Thanks, Jim. So 3 actions to cover from previous meetings. The first one was we discussed some time ago about the report that comes from the Acute Programme Board, and the current version is appended to the Chief Exec's report for today's meeting. There was a discussion around how do we sort of create a local flavour of that programme board for this board. What I would suggest is now we've got to the point where we are developing the governance arrangements for the Acute Provider Collaborative and the role of the Acute Programme Board within that. I think if the board permits, I think we just pause on this work and then just work out what that looks like, and then come back with a proper proposal, if people are happy with that.
Thank you. I don't see any dissension from that.
Thank you,
Peter. Thank you.
Second item was Nick raised issues or the support for people who raise concerns, and we have regular conversations about this through People Committee, and we've introduced the staff stories through that mechanism, which I think is a great initiative, and People Committee will continue to oversee the development and implementation of the Freedom to Speak Up strategy. So I would suggest we take those conversations through People Committee. And then the final item was around the training and development around EDI, and the original workshop has been delayed, but it's now been rescheduled. So that is in progress.
Thank you very much indeed. Okay, we can close those. Thank you very much indeed. We now move on to that part of the agenda, which is hugely important and is always well received by the board, the patient story. Janice, may I pass to you to conduct us through this as you wish, please?
Yeah, thank you, Chair, and thanks for having an opportunity to bring this story. Just before I hand over to Guy Young, my deputy, who'll talk us through the story, I think this particular story is quite challenging, I think, and quite action-provoking. I mean, we've learnt a lot from it, and it's also made us ask quite a number of other broader questions around access inequalities, particularly for patients with disability, not only for patients who are deaf, but we've got 1 or 2 other examples that hopefully I'll be able to bring back to you around people with poor sight or who are blind. It has really kind of prompted us to reflect and think quite hard, and you'll see some work that Michelle Dixon, our Director of Communications team, have been leading around the interpreting contract, and also some staff awareness, some sign language training, which all move us in the right direction, I think. What's very interesting, I guess, is at the People Committee, which you referred to, we had a very interesting story around disability from a staff member, and I'm sure as we go into 22-23, we've agreed that we'll have a mixture of staff and patient stories around some of the the important themes to patients and staff going forward. So yeah, over to Guy really for the story this month. It's British Sign Language Week, so it's quite a timely addition to raise awareness to that week. Guy, over to you.
Yeah, thanks, Janice. I think you've covered quite a lot of it. And I'll take the paper as read, but the story itself is really quite a simple story in that this gentleman came to our emergency department with an acute problem, and his means of communicating is through British Sign Language. He was with his son who was accompanying him, who's also deaf and communicates through British Sign Language. The emergency department staff recognised that he needed an interpreter, And I think I noted in the paper that this, you know, this is positive, that awareness that was required, and the fact that the ED staff weren't prepared to take no for an answer when they were told that they could, when they contacted the interpreting service and were told that they could expect someone in 48 hours. So they persisted, and we escalated it up through our contacts, and we managed to get someone to communicate with him through a virtual consultation within an hour. So for this patient, it was a success story, but of course the concern is that that's not always going to be the case, and that we shouldn't have to rely on an escalation up through various channels to get this. So I think, as Janice says, there's a number of learning points and actions that we're taking. The first is around how we source interpreters, and there's a project underway to review all our interpreting services, and this is prompted to a large degree by engagement with the communities. We're doing that, and we've just pressed pause on the retendering process for our existing contracts, so we can factor in all that feedback from the communities so that we get it right. The second thing is we have done some basic sign language and deaf awareness training for staff. We delivered this in December, and it was very, very positively evaluated. So we've managed to get some resource to train another 250 people. We are, as Janice said, at Sign Language Week this week, and there's some promotional stuff on the intranet through the use of screensavers and that sort of thing. And we are looking to get people, primarily those for unplanned attendances, A&E, acute admission wards, front of house teams, to engage with that training. And that is really where the problem is, I suppose. Where we know somebody's coming in for an outpatient appointment, for example, we have less of an issue getting interpreters. We're also looking at extending our use of hearing loops in some of the departments, such as imaging and outpatients. And finally, those of you who have been around for a little while may remember that we brought a story to the board. In fact, Jeanette came to the board and told her story of being a signed language user, and the issues she had when she came in for an investigation. And Jeanette worked with us very closely to develop this blue band initiative. So they're bands like you would wear when you go to a festival and that sort of thing, that highlight, make staff aware that the person is deaf and needs help communicating. And I particularly wanted to mention that, as unfortunately Jeanette died last year, but wanted people who may have remembered her to know that her initiative is still helping deaf patients within the trust. So that's the story. Thank you very much.
Thank you very much indeed, Guy. Thank you. Colleagues, would anybody, Sim?
Thank you. Thank you, Guy. Really welcome this report and this focus on disability and interpreting service. Very important both for deaf people and for people that don't have English as their first language. And obviously, I hope your review is able to find a service that is instantaneous and delivered online, that we have access to 24/7 to deal with a lot of issues that will come up that need immediate translation services. So really look forward to hearing who you managed to procure, and that service is fit for purpose, immediate, and 24/7. So look forward to hearing that.
Thank you very much, Sim. Julian.
Yes, it was just to really highlight some of the work that we did during COVID, engaging different communities that Bob and I were involved in. This was one of the main issues that was highlighted, was around translation services. So I think this work is really important, and thanks to Guy for taking it forward. I think it will make a huge difference to a lot of the engagement that we have with our different populations as well.
Thank you very much, Julian. I absolutely agree. Notwithstanding the experience of the individual and how tenaciously staff who were engaging with him strove to get the support that he needed. The thing I particularly was impressed with, Janice, is the amount of learning and action you have taken out of that experience into other things that will inevitably support other patients. And it's great to see that translation into wider benefit being taken on. And thank you very much. Janice.
Yeah, just really, it was just a reflection. I mean, on this case and another one that we've been dealing with was that there was an awkwardness amongst our staff, and I think they wanted to do the right thing, and they try to do the right thing, but sometimes they're not totally sure with patients and families where they're deaf or they're blind about how to go about doing it, and I think that was a really helpful insight, because you could assume that they might, and I think in terms of our awareness training, with Michelle and Guy, we've talked a bit about this, and it really is helping staff to ask the right questions, the open-ended questions, where they can get feedback, from patients and families about the best thing to do there. And then as patients with these kinds of disabilities use our service, often the patients know what they need and want to get the best out of it. And I think rather than close things down, we need to make sure our staff are opening those discussions up. And that was a really insightful bit of learning, I think, for us.
Thank you, and thank you. Well, if other board colleagues have no other comments or questions, then Guy, Janice, thank you very much indeed for bringing this particular story to our attention, and we're awfully pleased to see the amount of good action that's stemming from a specific event. That's excellent. Thank you very much indeed.
Thanks,
if I can move on to Chief Executive's report, please, and pass across to Tim.
Thanks, Bob, very much indeed. So a few things just to highlight that are in the paper. So just to start with operational performance and COVID, I guess it's worth noting that the numbers of COVID have actually gone up slightly. So if I take the numbers from a week ago compared to the numbers from the beginning of this week, we've gone from 12% to 15.7% of our beds occupied by patients who are positive for COVID. That means that we've gone from 116 to 149 patients who've been positive on this admission, and from 74 to 92 patients who were positive at their last COVID test. So we've been bubbling around sort of 11 or 12% for a while, but it does appear that in common with a lot of what you'll have read in the media, we have seen an increase. And of course, that does mean that we've got quite a lot of operational pressure on how we manage our bed base. And on our two sites with emergency departments, we already run at greater than 90% bed occupancy. And of course, if you have to create these separate pathways, it does make the operational challenge for the teams on the ground that much more difficult. And the team, I think, have done a really good job of managing the demand, and the demand is now back up to the demand that we were seeing in 2019-20. I guess it's also worth saying that the teams at the front doors of the hospital have also done a really good job of maintaining our ambulance offloading. So Charing Cross is very frequently the best performer in London in terms of offloading ambulances, and St Mary's, given that it is the busiest major trauma centre and has one of the smallest resus departments, is also acquits itself pretty well, but we are constantly working to try and make sure that we can get the ambulances offloaded in a timely manner. And to wit, all of the teams have been focusing on really trying to make sure that we keep the care flowing, as we say. It's a slightly unfortunate phrase in a medical context, but the back door of the hospital is really important in making sure that people can move through the system in an effective way. And we had our Best Together campaign towards the end of January, which has now led to a series of actions. We spent a week really focusing on how patients can move through our pathways as effectively as they can, and the Division of Medicine and Integrated Care led on that, worked really well. We've got a whole series of actions now about really making sure that we've got discharge planning as effective as we can have, really understanding what the timetable to discharge is in quite a sort of well defined sort of way, so that we're actually using anticipated dates of discharge as a driver of effective care planning, and real focus on the daily board rounds across the trust. And I think that has been helpful. I think we've also played our part in trying to offload other emergency departments. So as colleagues will know, we've been working across North West London with London Ambulance Service to change the conveyancing from some postcodes to try and give the Northwick Park Emergency Department, which does get a very large number of the conveyances, slightly decompressed, and that's been by diverting patients to both actually Mary's and also to Charing Cross. We've managed to do about 90% of our business as usual in terms of elective care, and just over 100% for diagnostics and outpatients so far. And we're planning, as you'll see, to do more than that as we move into the new financial year. The issues that we've had at the Western Eye Hospital have had an impact on our ability to deliver the whole of the elective programme. But again, the teams have worked very hard in a short period of time, both to get the Vanguard Theatre up and running in the car park at Charing Cross, and that opened for business on Monday of this week, and also other specialists have been very good about sharing their theatre time, particularly in Riverside. We have relaxed our visiting restrictions, so people are allowed one visitor per day for an hour, and it doesn't have to be the same visitor every day. Although it does have to be booked. Obviously, with the increase in community transmission of COVID and the increase in number of patients in the hospital who have COVID, we do need to think carefully about visiting. We will keep that under review. If we can relax it further, we absolutely will. But obviously, if we think we need to tighten it in order to keep patients safe, we will also do that. And obviously, it goes without saying, a lot of the patients in our hospitals are patients who, even if they are vaccinated, may not have the same good response that a normal healthy person would have to vaccination because of their underlying health conditions, or indeed the treatment for those. So I think it is something we will need to keep under review. One thing I forgot to mention is, just for the sake of clarity, about 50% of our patients who come in with COVID at the moment come in because of COVID, and about 50% come in and are found to have COVID just because we test everybody who comes in. In terms of vaccinations more generally, in terms of staff, 91, well, nearly 92% of staff have received doses 1 and 2, and 88.5% of those who are eligible have received the COVID booster, and 61.1% have received the flu vaccine. That puts us 6% above the London average for flu and 1% above the North West London average, and we're sort of in line with most other places for COVID-19. Important to note, we've got the new vaccination clinic for the 5 to 11-year-olds who are most at risk, which I think has been a really good initiative. If I move on to the vaccination as a condition of deployment, obviously this has been a cause of some consternation over a period of time. The government has now decided not to pursue that. it is interesting to note, I think, that we were running workshops for people to try and emphasise the benefits of vaccination, and the approach I think we've tried to take as a trust has been not trying to sort of, even when it looked as though it was on the cards, to suggest that people had to have it because that was the law, but actually to say, look at the evidence. If you've got any questions, come and ask us the questions, and to make a decision based on the data. And interestingly, we had about 1,000 people who hadn't had the vaccine. We ran a session with Professor Peter Openshaw, who very kindly came and gave us the benefit of his wisdom, and 450 people turned up to that, which I thought was really good. What was even more interesting was that after the VCOD rules had been relaxed, we ran another one, and 450 people turned up to that as well. So I think it does go to show that actually there is still interest in getting the answers to questions around vaccination. And we had a fantastic session at the all-staff briefing with Dr. Benar Talabani, who is a renal physician in Cardiff, a trainee who gave the most fantastic explanations about how effective vaccines were. There is, however, I think we only fair to recognise some repair work to do as a result of that whole process, because obviously our managers had started having some quite difficult conversations about vaccinations, and we do need to make sure that we have really taken account of that as we move forward. To note the acute care programme update, which is the appendix here. So the acute care programme board has been in existence now for about a year, and I think it has been doing a really effective job actually of embedding collaborative work across the sector. We noted earlier that in the first year of the pandemic, we had 251 patients who were moved between hospitals for critical care. And in the second year, we had 155. And I note the lower number is because we needed less transfers, not because we were less collaborative. 3,500 people so far have been transferred between hospitals in order to speed up their treatment by making optimal use of NHS resources. So I think that's a really good basis as we move forward with our common chair. In terms of the money, you'll note that we are on target to deliver a break-even for this year, which is good, and we are currently in the process of the operational plan for 22-23, which will be submitted the first draft tomorrow and the second draft at the end of April. CQC, we've not had regular CQC updates this year because of the Omicron outbreak. Colleagues will note the maternity assurance report, and I think this is basically really encouraging. So the trust was one of a very small number of trusts that was found to be completely compliant with the Ockenden recommendations, and also achieve compliance with all 10 safety actions of the CNST, which I think is very good. I think there's a lot of focus on maternity at the moment, and I think it is really important that this is an area that there are across the country quite significant workforce issues with, that we are absolutely trying to work through and make sure that we get our workforce planning right. And of course, it is an area where, when things go wrong, it is truly terrible for everybody. And so it is really important that when things do go wrong in this area, we are absolutely focused on making sure that we have learnt the lessons, which we absolutely are. Redevelopment, people will know we're on the 40 hospitals programme. We are awaiting the 40 hospitals submitting their sort of updated business case to the government, and our strategic outline case is sitting with them at the moment. And so we continue to engage with the National Hospitals Programme across all 3 of our campuses, which are included, and we'll update you in due course. Colleagues will know that in the Western Eye Hospital, we had to close a large chunk of the building because of a significant fire risk. We've done a lot of work since then to work out what the right thing to do is, and I think the right thing to do is actually to go back into the building, because that is the best way of creating additional capacity in the sector in the shortest period of time in order to try and get to grips with the backlog. And we think that we are likely to get the funding to get back into the building and to expand our operating capacity in the building through one of the capital bids that are currently going through, which will obviously be extremely good news. And we will try and get that up and running as soon as we can. And then finally, in terms of research, we've just had the redesignation of our clinical research facility, which is funded by the NIHR, which has got another 5 years of funding with an increase, which Professor Weber mentioned earlier, which is obviously an excellent result actually for the team. And we are going forward as part of the BRC, Biomedical Research Centre process, to be interviewed in April. But again, you can see in the paper some amazing figures actually of how the trust has managed to keep up with research. More than 10,000 participants in 342 individual NIHR portfolio studies, despite everything else that has been going on, which I think is a fantastic achievement. One of the things that we have really focused on and realised that we still have quite a lot of work to do is equality, diversity and inclusion. And we've had a number of really good things. The People Committee this month had an update on the ICANN network, which is our disability network, which is really beginning to get traction in the organisation, which was great to see. The Women's Network organised some fantastic things for International Women's Day. We had a workshop of 270 people attended, which I think was extremely well received. And the focus on becoming not just not racist, but actually proactively anti-racist as an organisation remains, and we have discussed a number of mechanisms through which we can advance those agendas. You'll see a list of some of the engagements I've had with stakeholders over the last month, and it was really good to meet not only Hammersmith and Fulham Save Our NHS, but also Brent Patient Voice and Ealing Save Our NHS a couple of weeks ago to talk about where we're going in the sector. And you'll note also that a few other exciting things. We've now got 3 fully refurbished staff rest nests. As people will know, we've spent now several £1 million on trying to improve staff areas. The rest nests have been done in conjunction with Taylor House Design Company, and they are absolutely fantastic. Actually, if you those of you who wander around past our screensavers will see the before and after pictures, and they are amazing. And I think the staff have really appreciated those. And we are rolling that out across the trust. And you'll note that the trust has been involved in 2 really interesting television programmes in the last couple of weeks. And then the final thing, which Bob has already alluded to, of course, is that we're very pleased that Matthew Swindell's our new joint chair is able to join us today. But of course, if Matthew is arriving, that means that Bob Alexander is going to be stepping down as the interim chair. And I would just like to, on behalf of all of the executive, thank Bob for everything that he's done in the course of the last year to pick up a £1.45 billion trust in the middle of a global pandemic and to steer it through the year has been an incredibly difficult task, and I have really appreciated all of the support you've given me personally and indeed the executive more generally. And that's my report. Thank you.
Thank you very much, Tim, and thank you for your kind words. Colleagues, any questions of Tim? We're asked to note the report, but questions. Andreas.
Thank you. Very good report as usual. Thank you very much, Tim. Just a very small question. I noticed that reviewing whether to continue to request a lateral flow test before visitors come in because they're not available for free anymore. And I just wonder whether that is really the right, if that was a decision, whether that would be the right decision, or whether we should just either offer it ourselves to visitors, or just request them to pay for it if necessary?
I think it's a very good question, and I'm sure Janice will come in and have a view. We have never checked the lateral flows. We've asked people to do them, but we have never checked them, partly because it then turns your nursing staff on the wards into sort of policemen, which obviously will be quite difficult. So I think we are still encouraging people to do them. We do actually have lateral flow tests on site that we can give people. So we will ask them whether they've had a lateral flow, and if they say no, we can offer them the opportunity to do a lateral flow. But we haven't made it absolutely compulsory. Janice will correct me if I've got that largely wrong.
No, I think that's right. I mean, the national guidance doesn't particularly make it compulsory either. I mean, I think our main message to visitors and families is if you feel ill with anything, don't come into the hospital, and that's the kind of starting premise. And then, as Tim says, we do ask people if they can to take a lateral flow and to again, not come in if it's positive. I think what we're anticipating seeing over the next, sort of months will be some more relaxing and some changes to the national guidance. The national guidance, is to keep our patients and our staff safe, and is slightly different to what the general public are experiencing when they're going about their business in shops and cinemas and other such like places, where the level of vulnerability of people they're coming across and the people caring for them is slightly different. So I think I don't think we'd want to at this stage be offering lateral flow. I think our preference would be to say, if you're feeling ill in any kind of way, don't come in, and if you can take a test, do take one for the sort of short to medium term until that advice is reflected on as we move through into the summer period.
Thank you, Janice. Andy.
Yes, very briefly, I think the advice not to come in, whether you're ill or if you're ill, is good and should be continued. There are many more viruses and infections than COVID, and just because you're COVID negative does not mean you don't pose a threat to other people in the hospital. And the reason outlooks for asthma in children have been improved is because the cycle of going to nursery with an infection, passing it round to everybody, was broken by self-isolation. So I think that advice should continue.
Thank you very much. Any other questions or comments on Tim's update? If not, then we note it. Thank you very much, Tim. And we move on to the operations and performance part of the agenda with the integrated quality and performance report. Julian and Claire to lead us through, and I think we'll start with Julian and then move on to Claire, please, as we go through the report.
Well, thank you. I'm very happy to. I'll try not to be repetitive. We've got some other papers on learning from deaths, etc., coming up, so I'll leave those details for those into that particular report. So this is really to say that I'm pleased to say that our instant reporting rate it dropped a little bit during the last phase of COVID, but not as much as we've seen in the previous heightened cases. So it's actually probably a good news story in that I think we are maintaining our ability to make sure we've got a high reporting culture, and we're continuing the work on that in focused areas as well. And that's also good because our harm profile has remained low during this period as well, with below averages of where we should be. So overall, from the quality point of view, a good place to be at the moment. Thank you, Bob.
Thank you.
Claire.
Thanks, Julian. Okay, sorry, did you want to ask your question before I do my bit?
No, can we do your bit, please, and then we'll do questions, and I'll bring people in. Thanks.
So you'll notice in the countermeasure summary reports for this month's performance report, which includes data up until January, that we've made some changes following our board seminar discussion a couple of weeks ago. So these are only some preliminary changes and a sort of a wider piece of work, but I hope that they're helpful. And essentially what it means is that when you have a look at the graphs, orange dots in terms of patterns or trends would suggest some cause for concern, whereas blue dots would demonstrate an improvement. So just in terms of our overall position for January, I won't repeat the elements that Tim's covered, but just I guess pick up a couple. We've got rather more orange dots than we have blue, which I think is reflective of the challenges that Tim outlined in terms of where we were with COVID, general winter pressures and our elective activity. All that said, I do think we've done a reasonably good job at balancing those risks against one another, but there is an awful lot more now that we need to do, of course, to get back to where we would want to be. So just in terms of our priorities for the next couple of months, we are going to continue to improve our performance against the diagnostic standard, and we are on track to meet the national requirement that less than 1% of patients wait more than 6 weeks for their diagnostic test by the end of March. As Tim said, we're really focusing on increasing our elective activity, and we have seen some improvements during February and March, but now that we've got the Vanguard Theatre with us and up and running, that will help make us, I hope, deliver a step change in what we're able to do in terms of our elective activity. We've done well keeping our cancer services going during COVID and the various other pressures, but we need to do more in order to meet demand and to deliver the faster diagnostic standard. And in the countermeasure summary report, it sets out some of the pathway redesign work that we need to do over the course of the coming weeks and months to make sure that we achieve that. And I'm sure Katie can answer any questions if there are. And then finally, as Tim said, we need to keep a focus on and really redouble our efforts on flow going through our emergency department. So we will particularly be concentrating on maintaining our ambulance handover times, improving them where we can, really looking at our ED waiting times, because there is more that we need to do to try and speed up flow through and out of the departments. And then, of course, focusing on our length of stay. And I was going to leave it there as a summary, but happy to take questions.
Thank you very much indeed, Julian and Claire. Kay, do you want to come back in with your point, please?
Yeah, now this, apologies if this is one of those, there's a few random bits of things and I'm drawing too many conclusions, but just to say it's great to see the progress that's being made. I mean, you know, given where we were 2 months ago, I know it's not where everybody wanted to be, but both in this meeting and in other meetings, it's clear we've got, you know, we're very clear on what needs to be done. So I know how much hard work goes underneath all of that. And I've been getting very good feedback amongst patients who have sort of been talking about the great service they've got. The only note, and this is not a criticism, has been in discharge management, and we don't have any any measures which are around, and I'm not saying we should, about people leaving, and whether we do effective discharge management so that they then don't come back and we don't get that repeat attendance. So sorry, that was a rather long-winded way to say, do we have any assurance that we're not getting people coming back within 30 days, or and we're comfortable with our discharge management? Because there's so much emphasis on the front, the sort of incoming. Are we assured about the sort of the final bit of the pathway?
Claire, are you best to start that and bring other people in as you think best?
I can certainly start. So first of all, thanks, Kate. I think it's a really interesting observation, and I will go away and think about what you said, partly because the way that we effectively keep the front door flowing is to place a huge amount of attention on the sort of the other end of the pathway. So there's a huge amount of work we do around discharge, although I'm not sure we pick up some of the feedback about the effectiveness of discharge in a qualitative way, in quite the way that you've just described. So I think there could be a gap there, which I'll certainly go away and have a look at. In terms of reattendances and readmissions, that's something we've been looking at actually across North West London, and as a sector as a whole and within each individual trust, our readmission rates have certainly come down quite significantly actually over the course of the last 12 months, and our reattendance rates have either come down or are stable. So I don't think there's a particular problem about people coming back through the front door. There's certainly not a problem that's getting worse, but I do think there's definitely more work we can do in terms of the discharge process and the quality of that discharge process.
Thank you very much indeed, Claire, and particularly important that there's a bit of learning across the 4 organisations in the collaborative, because there may be a bit of learning from others and doing things in a similar way that might be helpful in the medium term. Julian and then Tim, please.
No, thank you. It was just to follow on from Claire, because we do keep an eye on the readmission rates, but you've got to be slightly careful how you interpret those readmission rates, because we do expect to readmit some patients, so they'll be included in those figures, but we're not seeing a sudden rise in those, which is what we would then be concerned about if we were starting to see harm. And obviously we also monitor that through the incident reporting, the complaints and the instances. So there are different ways that we monitor that.
Okay, thank you, Julian. Tim.
Yeah, I mean, Claire's covered a lot of it. There is a very substantial national focus on discharge because of the impact that the back door has on the whole flow through. The danger, of course, is that you then move into a mode which says you just got to get everyone out as quickly as possible. And I think we're quite alert to that. But I think Claire's right. We probably don't collect as much quantitative feedback as we could. I think that one of the key things, we've got a lot of processes in place now to make sure that people that go home and have packages of care get the package of care, because in the past we've seen occasions where we thought packages of care were going to be set up and then they weren't. So we now have quite some belts and braces approaches around that side of things, and that's made a big difference. But I think the key thing actually will be what I was describing earlier, which is that really helping patients and their families understand the process of discharge from the beginning of their admission. Because I think one of the things is that suddenly a doctor says, right, you can go home today, and then everyone's sort of scratching around to get stuff. So this bit about having a clear anticipated date of discharge and understanding what the process is at sort of D-Day -1 and D-Day -2, so that people are prepared for the day when they go. And also, if they need to go to the discharge lounge because we need the bed earlier in the day, we're very clear about that in advance. So I think it's we're probably not as good as we could be at socialising what the process will be in advance, so that there's a sort of lack of surprises. So I think the two things we'll try and focus on are, we will try and see what we can do in terms of collecting that qualitative data, and we've already got the transformation programme in place, and Jeremy's team are leading it to really try and get that timetable properly nailed and communicated.
Thank you. And then some metrics coming out of that transformation, I think, would be very helpful for us in due course. Thank you very much.
I suppose the only difficulty there, Bob, is the quantitative metrics already look quite good.
Yeah.
It'll actually be the qualitative stuff, I think, that we'll need to focus on.
Yeah. Thank you very much indeed. I can't see any other hands up, colleagues, so we're asked to note the report. Thank you, Julian and Claire, for that, and we move on to the quality section. And as Julian referred to, a number of quality reports in detail here, which have previously been discussed to our quality committee. So Julian, I'll just let you take us through the reports, and we'll stop for questioning in the event that that's necessary. Thank you.
No, thank you, Bob. And to start off with the Infection Prevention Control report, I'm joined here also by James Price, our Director of Infection Control, who will be able to come in with some more details. But just to summarise, because I think it's important for me to say just how proud I've been of our infection prevention control team during this COVID, because they really have been at the forefront in ensuring that our staff, our patients are safe, and that outbreaks are dealt with very, very quickly. And they've been very effective in doing that. So I'm very proud of that particular response by them. I think the important thing here is that we're on track to meet our C. diff projection rates. Will be below our projections for C. difficile. We will be slightly above our Klebsiella infection rate because of some earlier instances earlier in the year, but that has been a national increase in those, and if we compare ourselves to Shelford, we're third lowest in Shelford. So I think we're in a reasonable position against national standards, although it will breach the imposed ceiling on that as well, is most likely by the end of the year. The MRSA one, we're also in ahead of where we should be in that. Now, there are 9 cases which have been attributed to the trust, although 5 of them are really where we've been involved. There are some which come from the community which end up with us as a trust, although we haven't really been, we couldn't really say we're the cause of those. So within those 5 cases with MRSA, at least 4 of those were in one particular area where we did specific work once we found this in a short period where they had a number of infections. And I'm pleased to say that that work was effective. We've not seen any further MRSA coming from that area. All of these cases have not been to do with the insertion of lines, which has often been the problem in the past. It's actually to do with the care of the lines. So we're developing more education programs and more targeted efforts to ensure that all our staff are aware of the care of intravenous access lines to try and prevent any further outbreaks of MRSA, which obviously is very important. But it's also important to note that no harm has come to patients during those outbreaks as well. So I think that covers the infection control. I don't know if there's anything James wants to add.
Thanks, Julian. Good afternoon, everybody. I suppose the only thing just to reiterate as well as part of this process is we're completely revamping our IPC practices in the education and training across the trust as part of this, not only line care, but understanding and supporting hand hygiene, PPE. And so this is a big piece of work that's coming towards a conclusion. And so I'm going to be pleased to help front that, hopefully by the soft launch by the end of the month. Thank you.
Thank you very much indeed, James. So we had a good conversation about this at Quality Committee the other week. Andy.
Yeah, just one other thing to bring out, the amazing achievement in terms of antibiotic stewardship, when there have been so many sick patients around, and the temptation is to chuck around antibiotics like Smarties. The antibiotic stewardship has been excellent, and we continue as a trust, I think, to lead the way nationally.
Thank you very much indeed for that intervention, Andy. So we're asked to note the Q3 report, and if there's no other questions, then we'll move on to the Infection Prevention and Control Board Assurance Framework. And Julian and James again, please.
Yes, and thank you, Bob. And again, I think this is a really important piece of work, and we've been using this BAF, I think, in the correct way, which is to really use it as a live document. And it goes through each week with the CRG, which is led obviously through myself and Raymond, although not mainly Raymond, to be fair, and really looking at how we're improving through that IPC BAF time and time again. It's also important to note that they revamped it very recently, and they add a lot of different criteria into that BAF, so we keep that process going. I'm pleased to say that we have no red elements to our BAF at the moment. We have a number of amber, but those have got action plans all addressing them against those, and I think that we would be online to say that we are successfully going to be able to meet those over a period of time. So I think this is a useful report, and I'm very happy, and James, I'm sure, will be very happy to take any questions on it. And thanks to James for all his hard work on this particular report as well.
Thank you very much indeed. I mean, I note that we're asked to note the self-assessment, and again we had discussion of this at the Quality Committee, and Andy, I think I'm right, in the Quality Committee endorsed the assessment. Well, we did, because I was there, and
it's in the summary.
but obviously a bit of technical failing on my part. Any questions or comments, colleagues? No, in that case, we note it and thank James particularly for his work, and Julian for leading our conversation today. Thank you very much indeed. Julian, staying with you, the deaths quarterly report, please.
Yes, no, thank you. And I think there are 2 elements of this I just want to highlight. One is around the HSMRs, because there's been a lot of discussion about our HSMRs. Now, I want to point out that our HSMRs have never gone to an area which I would be concerned about. They are all well below the figure that you would expect. But we did see a brief rise in our HSMRs earlier this year, remembering that 100 is your expected score and we were 76. So again, way below where there'd be any concern around that. But I'm pleased to say that recently that has fallen back again now to our previously very low levels. That has had the effect of we pride ourselves on being being in the bottom 5, and at the moment we're in the bottom 6 for that figure. And we've done some work with Dr. Foster to understand that position and make sure there's no areas that we should be concerned about. And so far we haven't identified any areas that we would be concerned about, but we have noted that a number of trusts have improved their HSMRs as well. So I think this is one to keep an eye on, but I'm not concerned about our HSMRs. And it's also important to note that our shimmy scores, which is the other way of calculating this, have remained in the bottom 5 as well and remained low. So overall, we're continuing the work to deep dive into the HSMRs just to make sure there's no areas that we need to be concerned about, and we'll continue to do that and report anything back to this committee. The second part of this is to talk about the learning from deaths aspect, which is our structured judgment reviews. We've got a very good well embedded process now with structured judgment reviews, where a number of colleagues do notes audits on every single patient who dies. They are able then to highlight any concerns that they have in their report. Those reports come to us, the medical director's office, and where they do have concerns, and when we've managed to look at the details in a little bit more detail, we will go on to do instant reviews and use our DataX system to continue any deep dives into those areas that they're concerned about. So far, we've completed one of those and no further concerns were identified during that SI process. And we've got one more under investigation at the moment. The others have not needed to go on to that level of investigation. So I'm assured that we've got a very good process for reviewing all our deaths, and I'm happy to take any questions.
Thank you very much indeed, Julian. And again, we had good discussion on this at the Quality Committee the other week, where we went into the relative standing point that Julian made in his introduction in some detail. Andy, is there anything you wanted to say in relation to the Learning from Deaths report?
No, nothing to add to that. Thank you very much.
Thank you very much indeed. In that case, colleagues, we're asked to note and we look forward to seeing this in the future, and actually, if it were possible to make it even better than it is, you will, no doubt about that. Thank you very much indeed. And Julian, last but not least, the National Patient Safety Strategy update, please.
Yes, I'll give a very brief summary of this because there was conversations at the Governance Committee on the Quality Committee around this. But we're actually in a very good position against this strategy, and Shona Maxwell has done a lot of work in comparing us and making sure that we're in line with the national approach now. So I suspect that's partly because we were working already with Aidan Fowler and the national team around some of the work that we were doing. So we're in a good place from that. There are some gaps in the national guidance which are still awaiting further information from, so there will be, as we get that further guidance, we'll be able to assess ourselves against that as well. One of the main aspects of this will be around training for staff, and there is a national training programme which has now been developed, which we will be rolling out across our staff over the course of this year. The other aspect of this is important is the patient involvement, and we're working very closely with our lay forum now to ensure that we've got good patient involvement in our patient safety strategy. Although, to be fair, we've always involved them in that patient strategy over the years as well. The final part of this is the patient safety specialists. At present, Shona Maxwell make sure that we're compliant with the national ask, but we want to go over and above that, and we're working with the divisions to ensure that we've got patient safety specialists embedded in all the areas that we require them, and we'll be able to report further on that as that work develops. Otherwise, I think the strategy is there, Chairman, and very happy to take any questions.
Thank you very much indeed. A very, very fulsome report indeed. I appreciate that. Questions, colleagues, comments? No, well, we're asked to note oh, sorry, Kay, sorry.
It wasn't a question. It was just, I may have said this before, but I think the just culture thing is so important. I mean, we focus on the incidents and the just culture. And having had the privilege to go to one of the Friday incident reviews, I could really see those behaviours in action, and I would encourage other colleagues, if they can, to go to those, because I think it's a really good live example. And we talked to board assurance, but I think that's a really helpful activity as well. So I just wanted to raise that in the public board meeting because I found it very helpful.
Thank you very much indeed, Kay. And I should have said, of course, that the Quality Committee will continue to monitor the implementation of the outstanding actions as identified in that paper. We should say that for the public board as well. Thank you for the prompt. So if colleagues are content, we note the agreed plans and we note that they will be tracked through the Quality Committee thereon. Thank you very much indeed. So you'll have noticed we've a slight amendment to the way in which we lay the agendas out now, where we ask the relevant committee. We have the relevant committee report following straight on from the relevant part of the main board agenda. So we have the summary report of the Quality Committee that I've made reference to a couple of times straight on, and I invite Andy as the chair of that committee. Is there anything he wants to particularly bring out of that committee summary?
No, I mean, I think we've heard about the excellent quality work. I think it would also be remiss of me not to highlight that there was a major incident declared with Lassa fever, and that our trust was extremely active in supporting that major incident, which has now been stood down. And I think it's fantastic, with all the pressures that have been outlined, that we were able to offer that support. And I'm sure this committee would want to congratulate all those involved.
Absolutely. And thank you for bringing that out. Any further questions or comments on the summary of the committee? If not, then I'll say thank you very much indeed for participants of that part of the agenda, and we'll move on to the finance report. And Jazz, please.
Thank you, Chair. Just going to highlight again what Tim said at the top of the meeting. At the end of month 10, which is 31st of January 2022, we achieved a break-even position, which is on plan, and we're forecasting to remain at break-even to the year end, which is the 31st of March 2022. In relation to our capital programme, we have a capital limit of about 80.2 million. Although we continue to closely manage the programme, we are still forecasting that we will deliver against that target and maintain a resilient cash position. So there are the three key highlights I just wanted to make, and happy to take questions.
Thank you very much indeed, Jazz. Questions, comments? I have one, Jazz. Unfair, of course, but this is a month 10 report, which talks about actuals to month 10 and landing a year-end position, and we're at the 16th of March, year-end in a couple of weeks. How confident are you? How assured are you that actions are in place to secure that our good position will be delivered for the 31st of this month?
I just want to reassure the board that we are absolutely on track to achieve the numbers I've just spoke about, Bob. So there's nothing that's coming out in the reviews that have taken place for February and an interim look at March that would indicate anything different to what I've already said.
Thank you very much indeed. If there are no questions specifically for Jazz, then we note the position and we move on to the board summary, the committee summary from the Finance, Investment and Ops Committee. Very clear. Andreas, is there anything in particular you want to bring out from that summary?
I mean, other than that, plans always have an element of uncertainty around them, and this year the uncertainty is even higher than usual through a variety of factors. And so we'll really need to keep very close track on how things are evolving. But there is just it is a bit of a stab in the dark. I mean, educated stab in the dark, but there's a lot of uncertainties that we're not quite sure how they will pan out.
Okay, thank you very much indeed. But we're asked to note that report. I don't see any hands up for questions on it, so we'll note it and move on. And we move into the people section of the agenda. And Janice, the annual nursing and midwifery establishment report.
Yeah, thank you very much. I'll be reasonably brief because I think the paper is quite self-explanatory. This is an annual review. We also do a mid-year review. It's a mandated requirement. The reviews take into consideration service changes, department moves, and any quality concerns that we've had or any issues staff have raised. You can see from the paper that we measure acute independency. It's, as I've said, nationally mandated, and we use an evidence-based tool then to take those acute independency figures through to telling us how many nurses and midwives that we require. There's an element of professional judgment then applied around geography of the unit and the skills of the individual staff within the team. And you can see from the paper that we've had some small additions in critical care. That's the intensive care unit, primarily to accommodate an expansion in critical care beds over and above what we were established for. In our maternity services, picking up some of the recommendations from the national inquiries that have reported, particularly the Ockenden review that we've touched on this morning. And then we've had some expansion within the St Mary's emergency department that required some additional staff, in part due to activity, but also due to the geography and layout of the unit. The establishment is the total number of nursing and midwifery staff that you've got available to you on a daily and weekly basis, but obviously just to make the point that on a daily basis, supported by the site teams and the divisions, the actual management of staffing levels against that was planned is a daily, sometimes hourly activity to make sure that we use the resources that we've got to care for our patients in the most risk-averse and safe way. So this is all done, part two of the paper, this is all done in the national context of quite a significant nursing and in some places midwifery shortages. And the second part of the paper, if briefly, although we'd had a deep dive that I'm sure Sim, my non-exec colleague, will talk about shortly at the last people committee into nursing and midwifery staffing, which was really useful. The second part of the paper in that context of national shortage, I've got a number of schemes within our trust and indeed across the ICS that look particularly at new roles, apprenticeships and recruitment retention strategies. And as I say, a number of these we've managed to move forward across our ICS, particularly, for example, schemes to pick up those nurses that are trained abroad but are not practicing as nurses in our healthcare system, but perhaps as nursing assistants and need some support to get onto the nursing and midwifery register so that they can practice as nurses. And we found over 300 of those people, and it doesn't seem a great number in northwest London, but it was slightly more than I thought we would find. And at our deep dive, we were challenged around retention. We've managed to bring our vacancy level down, but I think we still have quite a bit more work to do, and I really want to focus with P&OD colleagues and the divisional teams on retaining the nurses that we're recruiting, training and recruiting. We found that if they stay with us longer than a year, they stay much longer. And we've also found from our surveying of new starters and of those leaving that people come to us for education and training. And in our exit interviews, people are leaving because perhaps we're not offering that as transparently and as openly as possible, because we have lots of opportunities available in our organisation. And much of that, as I say, was discussed in our deep dive. So I'll stop there if I may and pass back to you, Chair.
Thank you very much indeed, Justin. So it sounds an inordinate amount of learning there to take into future tactics and strategies around securing appropriate staffing levels. Sim, I'll ask you to comment on that if you wish, and at the same time you can morph straight into anything in your committee report that you'd like to bring to our attention, please.
Thank you, Bob. It was exactly that, Janice, actually, that I was going to highlight, the deep dive that took place during the People Committee on nursing and midwifery. And as Janice said, you know, we did probe deeply and we share the concern about the pressure on staff turnover and retention and recruitment. But I think what I want to report here is that we feel confident that the initiatives that were shared with us at that meeting were innovative and hopefully will be effective in really mitigating our position. We're up against it like other trusts and other regions, but we feel assured that the activity that's in place will really help us secure the nurses and midwives that we require in order to deliver safe care. So I just want to highlight that, and I want to thank Janice and the team, the HR team, that have done a lot of work and continue to do that.
Thank you very much, Sim. And I'm presuming that the actions coming out of the deep dive and some of the things that Janice has spoke about will be continued to be monitored through the People Committee work plan for next year.
Yes, it's a major area for consideration, and it won't drop off the agenda.
Excellent. Thank you very much indeed. Any comments or questions of either Janice or Sim for the specific report or the People Committee summary? No, in that case, we're asked to note both, and we do, and thank you both very much indeed. And can we move on to the governance section of the agenda then, please? And I'll pass to Peter for the approach to board effectiveness.
Thanks, Chair. So this is the purpose of this item is just to note that as per previous years, we are just about to launch our year-end process around our committee effectiveness and annual reporting through our committees. So we're planning to send out the effectiveness questionnaire this week. So I ask all board members to complete that if possible. We're following the same formats as we did last year, so we can compare results against last year. And we'll also then go through the process of writing the committee's annual summaries, both of which will then go through the committee cycle in May, so that we can then input into the annual report.
Okay, thank you. If there are any questions on that, Kay?
I'm sort of used to a cycle where at some point there would be an external board effectiveness exercise. I'm not necessarily advocating it for this time, Peter, but I just wondered how we factor that in, because we've done quite a lot of sort of self-reflection.
So foundation trusts actually have a requirement to go through an external review every 3 years. We as an NHS trust don't, but we tend to rely on the well-led reviews that we have through CQC, and we remember we had one a few years ago. So we are probably due, but given the changes that we've had over the last 2 years through COVID, and also the changes in sort of leadership, etc., we didn't think that this year was the right year to do that. We may want to think about next year whether there's something that we want to do in terms of external review. I would also add we rely on our internal auditors also through the process that they go through. They've done a director review, a divisional level review, and they're continuing to support us in that. So we do take some assurance from their external reviews as well.
Thank you.
And I think it's one that we'll sort of take away and think about, but this year is not the right timing for that, I don't think.
Yeah, accept that completely. But it might be something that Matthew would want to consider, given his role over 4, 2 of whom will through one process and 2 of whom could through another. There might be something sensible about learning and bringing that together in some way. But Obviously, that will be for Matthew to determine over time. Thank you for raising that, Kay. And then moving on from that, then the board summary or the summary for the board from the ARG committee on the 10th of March. Very full summary. Is there anything in particular you wanted to draw out to make sure we didn't miss?
There's just 3 points. I think Peter and the team are doing a lot of work planning for next year. We're obviously very cognizant of the fact we've got changes, obviously the chair arrangements and the different working across the acute provider collaborative. So it's going to be quite an agile process in terms of thinking through our assurance activities for next year. But I know the team have done a very good job on trying to see which committees need to do what that's mandatory. And we are going to have a meeting with the committee chairs this month to just sort of regroup on that. A large part of this meeting, and I think it's important to just raise it given the situation in Ukraine and the escalating cyber threat, was IT related. This is we actually started doing quite a lot of work back last year at really looking at our technology assurance, and the executive worked with the with internal audit and have been looking at the sort of audit universe and where gaps might be, and we had a deep dive on a couple of areas which have highlighted some actions which the committee will keep on. But I just thought, given some of the escalating risks around that, it might be useful to say about our approach to technology assurance. And then at our last board meeting, we heard about the Western Eye, and just so the committee received the Fire Improvement Notice Action Plan in an overview, and we'll be keeping an eye on that. That's coming back in July. So that's just to finish on for the last board meeting.
Thank you very much indeed, Kate. All important points raised. Thank you. Tim.
I guess just to build on the cybersecurity thing, just to note, and Kevin might want to come in, but we have now done an analysis of where there may be gaps and have committed not inconsiderable amount of resource to making sure that we have blocked those.
Thank you very much indeed. Kevin. That's Kevin J. Sorry.
Yeah, just to confirm what Tim says. I mean, obviously there is heightened risk at the moment, and this is a real area of focus for us. And as Tim says, we take a very sort of an approach very much based on the understanding of the risks, and we brought some investments through to the executive and had those funded, and we're moving at pace to put in place additional protections.
Thank you very much indeed for that confirmation, Kevin. Okay, so we note that summary report. We then move on to the slightly unique combined governance light committee that I chaired in February. Again, we're asked to note the report. Clearly, if anybody's got any questions or points, then I'll come to that in a moment. The most important point that I'll make, though, is that the actions and issues raised in this summary have flowed back into the relevant committee that they should go to in either the March cycle just gone or the new cycle to come forward in 22-23. But are there any questions or points of clarification? No. Then we note that report, and thank you to the Secretariat for producing it for me. We then move on to other committees. There's a summary report here of the Redevelopment Committee that I chaired on the 8th of March. Again, it's here for noting if there's any questions or points of clarification from colleagues. No, thank you. Then we'll note and move on. So that's the that, with the exception of any other business, that's the substantive part of the public board agenda completed. Just one bit of AOB from me. So as Tim's alluded to, this is my last board as interim chair, and I just wanted to put on the record what a privilege it's been to serve in that capacity for the past 12 months. And again, for the record, I'd like to thank the entire board for all the effort and work leading this fantastic institution over the past pretty unique year. And then moving on from that, actually, I look forward to something of a renewal in 22-23 under the leadership of our new chair in common, Matthew, who I introduced at the start of the meeting. And I wonder if, before I go open it up for questions from the public, if Matthew would like to say a couple of words of introduction.
Thank you, Bob, and let me echo other people's thanks to you for what you've done over the past months, and also for your support in welcoming me in this pre-takeover period. It's I'm looking forward very much to the challenge. I do think that across Northwest London we have a unique opportunity in our acute sector. If we look around what we're doing, we have, as Julian said, some of the best clinical outcomes anywhere in the NHS being delivered here. We also have some of the best management and operational processes. If you look across Northwest London, we also have some of the best engagement in population health improvement across Northwest London, and all of our trusts are on an upward trajectory. I'm excited about the opportunity and would set my aspirations no lower than this ought to be the best health system in the country. And if we bring that together with the remarkable university that we're associated with, we can make an international impact.
I'm sure. I don't think there'd be anybody that would not want to go along with that aspiration of improvement and success. And thank you very much. And as I said before, it's great to have you here. So on that basis, if colleagues are content, I'll close the business part of the board and we'll move to questions from the public. I don't believe we've had any questions in advance.
No, it's checked this morning, so nothing in advance.
But I will pass across to you, Peter, if you could manage this little bit of process.
Thanks, on my behalf. So as you say, so we've had no questions submitted in advance. So I think if we move directly to questions from members of the audience, in terms of how we do this, I first of all ask people, if you've got questions, to raise your hand, hopefully electronically, and then we can pick them up through Teams. If you can't do that, we've re-enabled the chat function, so please just put something in the chat to say you want to raise a question. Failing that, plan C is just wave your hand and we'll try and pick it up, but preferably raise hands. We'll give everyone a couple of seconds just to try and do that.
Yes.
Yeah, Mr. Keegan.
Yes.
Mr. Keegan, you're on mute, but you're more than welcome to raise your question.
I am not on mute, I hope. I wanted to go back to item 12, learning from Death's quarterly report. I think I heard that you are now making sure that you've got notes on this, which should be fine if the patient actually dies in the hospital. But what is your procedure for patients which are discharged and then die at some time later? Like, the question is, how long later would you be actually involved in actually making sure that you keep up the records of of how they died and why they died and etc. And moving on from that, there's also the question, I think you should be aware that at the moment there is a survey on end of life and palliative care that's going around the northwest, London northwest, and a couple of things on that. First thing, I have heard somebody report that there is a difference between palliative care and end of life care, and I wonder if anybody could actually tell me what is the difference. And secondly, how much is the trust involved in this survey about palliative and end of life care, especially where their patients are involved? Is that okay?
Yes, of course it is, Mr. Geoghegan. I wonder if your first question is best directed at Julian to answer, and then on the palliative care, I'll ask Katie to give a view.
No, thanks very much for your question, Mr. Geoghegan. And you're absolutely right that there is a gap there, but the next stage in the learning from deaths journey, I suppose you'd call it, is that all deaths in both in the community and in the hospital will go through the same process, and there will be obviously the people who do these reports, although they may be employed through us, and the trust will have that responsibility to care for its community deaths as well. They do actually report directly to the coroner as well. So the answer is that this will be addressed when we take over looking at all deaths across the whole community.
Thank you very much indeed. And then could I ask Katie to comment on the palliative end of life care definitions, please, and pick up on the survey or knowledge thereof.
Thank you very much, and thank you for the question. And I appreciate it does sometimes give some confusion. So palliative care is not the same as end of life care, because actually it encompasses the care of a patient at any point in their disease, and it really focuses on symptom control, quality of life, improved communication between teams, between patients and family. So so a lot of the work is actually with people who are going to fully recover and live a long time, but they just have very specific symptom control or communication or decision needs at the moment. End of life care, we tend to reserve to focus really on the needs of people who are dying, either longer term needs if they've only got a very short prognosis, like a year or two, or really sometimes around the very imminent death in hours or days or weeks. So it's just really trying to be able to focus the care and the attention on the needs of the patient and the family very specifically at the time they need us, and that's why the words are slightly different now, and palliative care is no longer synonymous with end of life care. To reassure you, we are very actively involved in the current survey and the current review that is going on, both at a local and national level. And that really is reflecting with what Julian said as well, is what are our needs, both in the community to service and support other staff, patients and family, really at any place that they're being looked after, whether that's community, a nursing home or hospice, or in hospital. So we engage very detailedly with our North West London colleagues, and that is a primary care, community and hospital based system. But that we are engaged and involved with, and certainly I can bring back when we certainly have some more knowledge from North West London and what the survey is going to come out with the recommendations of.
Thank you very much indeed.
I hope that helps.
Oh, thank you very much for your answers. I just quickly asked Dr. Redhead, that he did say that there was something going to be put in the position in the future about recording all deaths, hospital and community. Is there a timescale for that?
You're on mute, Julian.
Sorry. There is a timescale. I can't remember exactly what it is. I think it is towards the end of this year, and it's to do with, I mean, this is a national programme, not something that we're dealing with locally, and it's to do with the national guidance coming out. But we're in line to be able to put it in place as soon as we're allowed to through the national guidance.
Thank you for that. If there isn't anybody else, may I have one more question?
Oh, okay then.
This is about the care bill. There's a bit in it about discharge to assessments. In the meeting, you've been talking quite a lot about your discharge process, and there's a possibility of discharge to assessment coming up instead of the other way around. What does the trust feel about this in particular?
Shall I come to you first, Tim, and you can suggest who might best be?
Thanks. So discharge to assessors, I mean, it's been around for a long time, I have to say, and we haven't really galvanised it until actually during the pandemic. And one of the reasons it has been slightly galvanised during the pandemic is we've taken away the financial disincentives to do it properly. And I think there's an interesting question about, as we move forward, how we then think about it. Intuitively, it's actually the right thing to do, provided that obviously the patient is stable enough. Because what you want to do, particularly for doing OT and physio, is to make sure that you understand how the patient can function in their own normal environment. So it's all very well to walk up and down the stairs in the hospital. It's all very well to go to a sort of OT kitchen in the hospital and make a cup of tea. Actually, what you want to see is what are you like in your normal environment. So when it works well, you get very good coordination between the hospital and the community teams. They know when the patient is going to go home. They can be there within an hour or two, and then they can do the assessment and get the stuff, any support that's required, sorted out fairly immediately. And obviously, you know, you'll have an idea about what that's likely to be from the inputs that you've had whilst you've been in hospital. So I think it's a good thing. And one of the challenges I think for us now is to make sure that we can continue to do it as well as we have been doing it as we move out of the sort of COVID emergency and make it business as usual.
Thank you very much indeed, Tim.
Thank you for your answer and putting up with my questions.
Quite all right, Mr. Geoghegan, quite all right. Thank you for asking them. Anybody else have any questions of the board before I bring our session to a close? Not that I can see. In that case, may I thank you all for participating, attending. Our next meeting at the moment is scheduled for the 25th of May 2022. I look forward to seeing everybody then. Stay safe, take care. Thank you very much indeed. Bye-bye.